Septic arthritis can be a serious complication of both gout and rheumatoid arthritis. It can cause significant destruction of the bone and cartilage area in period of days, and even lead to significant morbidity and mortality to the patient. Cases of patients with a known history of gout with concomitant septic arthritis have been documented, but they are rare. We report a rare case of septic arthritis with superimposed gout in a patient with history of rheumatoid arthritis. This is a 75-year-old male with a past medical history of gout and poorly controlled rheumatoid arthritis managed with immunosuppressive therapy that presented to the emergency department with a 2-day history of right knee pain, swelling, redness, decreased range of motion, and subjective chills and fevers. The patient described the pain as constant stabbing, 10 out of 10 in severity, associated with movement and weight bearing. Current symptoms were different from his previous rheumatic or gout flares, which also prompted him to present to the ED. The patient was prescribed oral prednisone 3 weeks prior to presentation for suspected rheumatoid versus gout flare, as well as an intra-articular right knee glucocorticoid injection 2 days prior to presentation at an outpatient clinic for presumed gout versus rheumatoid flare. Initial vitals were heart rate of 129 beats per minute, blood pressure of 161/80, and temperature of 103 Fahrenheit. On physical exam, the right knee was diffusely edematous, warm, tender to palpation, with limited range of motion due to pain. Lower extremity pulses were intact with no neurological deficit. There was also associated tenderness to palpation in the bilateral shoulders, elbows, wrists, and ankles. Bilateral ulnar deviation of the wrist and proximal interphalangeal joints and edema of MCP joints were present. Initial labs show a hemoglobin of 14.6, total leukocyte count of 16, ESR of 39, CRP of 39, creatinine kinase of 638, creatinine of 1.8, and serum uric acid of 9.0. Right knee radiograph revealed advanced joint space narrowing of the medial compartment and patellofemoral joint with 3 compartmental osteoarthritis. Arthrocentesis show a total leukocyte count of 65 with polymorphonucleoside predominance, uric acid level of 6.9, and positive monosodium urate crystals. Synovial fluid and blood cultures reveal of Streptococcus agalactiae, and patient's antibiotics were de-escalated to IV Rocephin. Patient was also subsequently underwent arthroscopic knee debridement with resolution of septic arthritis manifestation. What makes our case unique is patient's past medical history of rheumatoid arthritis managed with immunosuppressive intra-articular joint infection that made him increasingly susceptible to septic arthritis with a superimposed gout flare. In one study, found that 43.5% of septic arthritis patients also had evidence of gout arthritis, but none of the patients had a history of rheumatoid arthritis. Differentiating between a septic and gout joint is crucial, as mortality for septic arthritis is 3%. Treatment of rheumatoid and gout include first-line agents like glucocorticoids, NSAIDs, and colchicine, all of which carry relative contraindication in our patients with an active infection and acute kidney injury. There's currently limited evidence and guidelines regarding the approach and management of similar patients. There are no prospective randomized trials claiming arthrotomy is superior to repeated aspiration of an infected joint, but our patient care necessitated and benefited from operative drainage and is the preferred approach by most orthopedic surgeons. In conclusion, it is important to take into consideration patients' comorbidity, since it can come in direct conflict with the standard of care for the presenting illness, and further investigation might be needed. In our case, interprofessional collaboration was necessary to provide coordinated care in this rare multifactorial presentation.